you can review your exam up until the next exam is given, so there's no absolute must-do today or tomorrow. But the sign-up sheet for today and tomorrow is up there in the front. You get 10 minutes to review your exam. I can answer any questions you might have. Most of you have 6% more than what you actually got. There were 3 questions that I accepted multiple answers on. So if you got it right, you didn't get extra points, but the majority of you got 6 extra points. I don't remember all the questions. One was the one about cultural awareness. I don't remember the question, but not everyone did well on that. One was the lobes of the lung. It was on the left side. Where was it? Upper, lower lobe? Those who said middle lobe, there is no left middle lobe, so I didn't accept that answer. But I did accept the left, upper, or lower. I can't remember. Did I just say 3 questions? Oh, those are the 3. Okay. If students get if the question has less than 50% correct, I review it to see what the problem was with the question, who answered what, and look at what could reasonably, even though it's totally wrong. So even though you got it wrong, you got credit for it. That doesn't mean the next time if you should ever see the question again, that 2 answers are correct. Does that make sense? Okay. So congratulations on doing well. Overall, it was a great test statistics. So good job. I ended up, I think, on Thursday with this slide, assessment of cognition and dementia. We're still following up the final couple of slides for dementia. In 2 weeks, all of you will be going to a senior center or a adult daycare health center, and you will administer the mini mental health state exam or status exam. You will interview someone and give them that exam as part of your interview. And the mini mental status exam is a test of cognitive abilities. So we would give it to people who we suspect may have cognitive decline, memory decline, such as the early stages of dementia. The highest score for the mini mental state exam is 30, and the lower the score, the greater the severity of the dementia. Keep in mind that if you administer this test, the individual must be able to read, okay? If they don't have reading skills, you can't administer the test. But I don't think we've come across many people who couldn't read. Maybe they couldn't read anymore because of the declining state of cognitive function due to being in the last stage of dementia. But they should have the ability normally. If they had the ability to read, you can give the exam to them. It looks at orientation, and basically orientation is what you're checking when you're giving this exam, is are they aware of where they are in the present? What date and time is it? Are they aware of what year it is? The registration is you're going to give them some instructions, and then you're going to say, I'm going to give you whatever, 3 numbers or 3 words, and then I want you to repeat them. The recall is you give them a few minutes later, I'm not sure exactly what the instructions say, or at the end of your interview, to say, do you remember those 3 words that I gave you at the beginning, and see if they have recall. And then language is you give them something, you say, can you read this and do what it says? So it might say, take this piece of paper, put it on the desk, and put your left hand on it, for example, a 3-step instruction. So that would be language and trying to determine if the person can actually not only read, but follow the instructions that you give them. There are other assessment tests that other facilities may be giving patients, but the mini mental state exam is probably one of the most commonly used ones. It will be part of your senior interview. Okay? So if you're caring for dementia patients, the role of the nurse is to provide support to caregivers. If they come into an acute care setting or in an adult day health care setting, they will often be cared for by family members. Keep in mind that if you have a family member who has dementia, who has Alzheimer's disease, that's probably the most common type of dementia that we see, that there's a book called The 36-Hour Day, They truly have caregiving responsibilities 24/7, 365 days a year, and it never ends. So interview them as well and see how they're doing. They need to have opportunities for caregiving relief. They need to have opportunities where they have some free time. So there are agencies, the Alzheimer's Association has lots of volunteers, for example, who may come into your home to give some relief to the caregiver so they can go shopping or have, a couple hours or an afternoon off. If you notice that they're looking really tired, interview them and ask them if they have some sort of support system in place so that they truly can have some time, even though they may not get away from home, a couple of hours, a couple of days a week, that they have some free time. There are also places that, like long-term care facilities that have dementia, specifically devoted dementia units, that will take someone maybe for a weekend so that the family caregivers could actually get away from home. So provide supportive nursing care, ascertain what state of dementia they're in, and then focus the care that you provide on that level of dementia that they are exhibiting. Give family members and patients as well accurate information so that they can develop strategies on how to deal with the family member as well as the patient. In the early stages, you may want to ask them to consider what to do about their will, for example, completing an advance directive so that while they're still cognitively able to function, that they can share with family members what it is they want as the disease process progresses to the end stages. Provide referral assistance if placement in the nursing care facility becomes necessary. There are all kinds of lists. For example, here in Orange County, there's a booklet that family members are often given, and it lists every nursing home that has units that are focused on dementia patients. Not every long-term care facility has a dementia unit, but some of them do have specialized dementia care units. So overall, in general, there are general interventions for dementia. Frequent assessment screening will assure therapeutic interventions that match the level of their ability. In the early stages, they may be able to go to arts and crafts and not perhaps to remember all the instructions, but while each instruction is given, each step, with reminders, they can actually participate. As time goes on, they may just go to activities and be present, but not actually do them because they can no longer comprehend the instructions. So some of those other cognitive tests, I mentioned the mini mental state exam, which is the one that we use. There's also one called clinical dementia rating and the functional behavior profile. Use very slow and gentle and reassuring touch. Never talk to the patient until they've seen you. As dementia progresses, these patients have no sense that anything exists outside of their vision. So they don't know that there's something behind them, for example, that there is other parts of the room perhaps that they're in, or that you've even entered the room. So if you started to talk, it'll frighten them because they don't know where the sound is coming from. So make eye contact before you touch. Stimulation should be as focused as possible. I mentioned that, for example, the activities. Drug therapy, there are a number of drugs. I think there's a new one now as well. Drug therapy has not yet been proven to make a difference. When patients are initially put on these medications, family members report, and sometimes patients report that it's in the very, very early stages that they do have better level of functioning. But over time, they lose their effectiveness and the disease does progress. So it may stall the progression for a short period of time. But there's no medication yet that has been found to actually stop the progression of the dementia. Communication, in terms of just the general population that has dementia, communication is critical for you to understand what these patients' needs are. Communication with Alzheimer's people gets more and more difficult because the person may have may have difficulty understanding what you said. Remember, they can't figure out what the meaning of the words are anymore. They can no longer name common things that they may have in their environment. They may not know what things are called anymore. So they're very sensitive to how things are said. So if you are getting irritated because you told the person your name 3 times already in the last 2 minutes, and you go, oh, I told you 3 times my name is, I'm a student, that sort of, any sort of sense that they get that you're upset with them will agitate them and probably change their behavior. They get agitated as well. It's a very calm, quiet approach. Avoid arguing about reality. We talked a little bit, I think it was in Module 2 or Module 1, about communication, how to communicate with older adults. If they have memory loss, do you remember what that communication about reality was called? For example, the person who says, oh, I need to go home, the school bus is coming, I need to leave, it's time for my kids to get out of school. But you know that they're in a long-term care facility, and you just sort of distract them by saying, I know you have to go home. Acknowledge their reality, because their brain is now slowly checking out, losing all the memories that have been built, and eventually all that's left is those distant memories. It keeps ratcheting back. Okay, so what is that called? Does anybody remember? Accepting the reality for what it is. What's it called?
Validation.
Validation. You should know what that's called. You validate their reality. So they cannot separate the past from the present. And they may not know who you are. So don't argue about them. Just carefully try to understand what it is they need. And then acknowledge whatever their reality is, instead of saying, no, they may say, my husband never comes anymore. Haven't seen him for years, and he just left. So instead of saying, oh, he was just here, that'll agitate them, because they'll realize that split second that they cannot remember their own spouse. So then you say, you know what, and even if the spouse hasn't just been there, why don't we give him a call? So that they can have that. They may not be able to express all their needs, but maybe they just need to know that their spouse is still alive and maybe coming to visit. So you could just try to figure out what it is they're trying to tell you, and then try to meet that need. Reassure the person frequently. So if the person continues to say, I need to leave, I have to pick up my kids from the school bus, then continually reassure them that you are caring for them today, and when 2 o'clock rolls around, you will make sure that they get to the school bus. Keep in mind that they may keep asking questions. They may not remember they already asked it before, same as your name, they can't remember, and they don't know what time 2 o'clock is. So they may tell you, because they used to pick up their kids at 2, but they won't be able to tell time at that point. So just reassure them, I'm caring for you today. In the meantime, let's go play bingo. Or let's go to do some arts and crafts, or go to the cooking class. Use lots of distraction, because if you argue with them, their agitation level gets worse. So try statements and not questions. Do not ask them if they have several outfits in the closet. Don't hold 2 or 3 up and say, which one would you like today, because they can't decide. So here is your pink pantsuit. Why don't you put this on today? And don't give them those choices today. That just agitates them. Or they'll say, I want this, and they'll choose 2 tops without pants. So then if you show, oh, you need pants, no, I don't want pants. So just show them a complete outfit that, that's theirs, and say, this is what you're wearing today. There are lots of personality changes, especially the first stage. Many of your patients will be depressed, inpatient or outpatient. So if you're in the community center and they have daycare or adult day health care that you're going to go to, then make sure that if they're truly depressed, try to reassure them, but understand why they're depressed. They have these moments of clarity where they realize they can't remember anything. They can't remember their own family members. They can't remember what they look like. Sometimes they're seeing things that aren't there. They have hallucinations. So if they say, you know, that, like I think I explained to you, my mom would say, get that woman out of here. But she didn't recognize herself in the mirror, then you just need to just reassure them that you are seeing things that I don't see, but let's move away from here where, you know, if they're seeing spiders on the wall or whatever, let's just move away from here. Let's go sit over there and have some juice or whatever. So don't say, you know, you're not seeing anything, but instead of saying that, be positive. I'm not seeing what you're seeing, but since it's upsetting you, let's move away from here. Some of them will see spiders on the wall, or they'll see ghosts. They'll see people that aren't there. It's just hallucinations. So as far as communication is concerned, the world can be a very, very scary place for people who have dementia. So try to see things from their point of view, reassure them, and just magically use your therapeutic communication skills with them. There are some primary interventions that are commonly used in care facilities. One is the environment is generally very structured in nursing homes, if they're in a nursing home, in family homes as well. Keep in mind that the dementia patient is very fearful of everything, fearful of their own shadow, fearful and very anxious because they just don't recognize anything, and they have periods of time where they're kind of lucid and they recognize how absolutely disoriented they are. So they need to have a very structured, calm environment, and for that reason we try to assign the same caregivers to the same patients in long-term care every day. The same caregiver isn't on every day, but when they are on, they will have the same person caring for them, and that's why those long-term care CNAs know the patients so well. They're always assigned to the same group of patients to reassure them that their structure and their environment and the care routine is consistent from day to day. And they need to develop trust. If they see a new face every day, they really get agitated. They may not know who you are, but they will recognize that you're a familiar person to them and that they care for you, that you care for them. The validation therapy, again, is for severely demented patients. In the later stages, the third stage of dementia, use a great deal of validation. Do not argue with them. And if the patient says, you know, he's got breakfast and I don't have breakfast, but you already took the breakfast tray away, maybe they're still hungry. Offer them something to eat. Instead of saying, you just ate everything on your tray, I just took it away, don't you remember? Well, no, they don't remember. So bring them some crackers or something, or bring them a cup of milk, or maybe have some Boost, put some ice in it, and give them some high-protein drink. Recognize that they can't tell you anymore that they're hungry, but maybe they want something else to eat. But most of the time you can distract them. If you know they ate everything on their meal tray, then maybe you can distract them and maybe, you know what, we're going to get dressed first, or do something else, and they'll forget. Sometimes there are triggers that make these patients very agitated, and they'll scream if you try to do anything. Anybody come across some of those patients? Yeah, so how did you deal with that?
Well, the CNA just redirected, said there's just certain people that she's just not going to have it.
Yeah, and some of these patients, if you're the student, it's like, oh my God, did anybody hear? They must think I'm really hurting this patient. You know, it's kind of embarrassing thinking, oh my gosh, you know, she's screaming. They must think I did something really wrong here.
I got the screaming help.
The screaming help,
yes. I mean, like, full blast. Help, help. I was like, oh my God.
Yes.
I wanted to turn around.
Yes. And we had a patient at one of the care facilities that I went to a couple of years ago, and if the student walked in, a new face, and started to help care for the patient would say, she's killing me! She's killing me, really loud. And then if the student continued, the patient would just scream at the top of her lungs. So can you imagine if you're a student and this is your first experience, like, oh my Lord, you know, what am I going to do here? So often it helps to have the CNA explain to you. But if they do have those screaming type of behaviors, find out from the staff, or if you're with the continuous caregiver, certain things will trigger that sort of behavior change. Pain. If you know that one of their diagnoses is they have arthritis, give them some Tylenol for their pain. They can't tell you anymore they have pain. But if their behavior suddenly changes, there is a discomfort. Maybe they need to be changed. Maybe they're wet or soiled. Maybe they're hungry or thirsty. Try to figure out, and if you were the caregiver, you would figure out that, oh, if we just give her some Tylenol, her joints are probably hurting, we just did range of motion, we just turned and moved and whatever. And then maybe in the future give it to them before you start moving them around. But they can't tell you anymore, my knees hurt, my back hurts, or whatever. When they're still in that second stage of dementia, and if they're in a caregiving facility, they wander. Some of you may have seen in a lot of facilities that don't have dedicated dementia or Alzheimer's units, they will try to keep all of the patients in a wheelchair because of the risk for falls. And they'll put like a wheelchair alarm type of thing so that if they get out, somebody will come to them. In true dementia units, they will allow them to wander. They will put like an arm or a leg, an ankle bracelet on them that will set the alarm off if they go out the front door. But it doesn't set the alarm off if they go into the garden. They often have wandering gardens, and they can go outdoors as long as they're still able to be safe on their own. But unfortunately, many people who are in long-term care facilities are subjected to having to sit in a wheelchair because they know they really don't know where they are. They don't want them to fall and have lawsuits. But the longer you can keep them mobile and active, the better it is for them. The longer they sit in a wheelchair, the sooner they forget how to walk. Pretty soon so, if they do have an Alzheimer's unit, they allow them to wander. Instead of asking them, can you take them to the bathroom, just toilet them every 2 hours. Just take them to the bathroom, and some of the CNAs in those units are just geared to doing that. And it keeps them continent for a long period of time. But they wouldn't be able to tell you, now it's time to go to the bathroom. So they toilet them every 2 hours. If you do have somebody who's screaming and they wear glasses, then provide them with their glasses and their hearing aids so that they're aware of their own environment. If they have prescriptions where they can't see anything clearly, it's very confusing, but they can't tell you they need their glasses. So if they're not on, put them on. Maintaining the routine is really important. So the same caregivers as I mentioned, sometimes people who start screaming are tired. So if you were one of those people who's caring for those patients, sometimes they just need to go to bed in the afternoon and take their nap, but they can't tell you that anymore. I talked about the hallucinations, the paranoia, wanting to go home. How do we prevent that screaming every time a family member comes in, they want to go home, or they cry, they want to go home? How do we address that? Redirect and bring in their favorite chair from home if the facility allows it. Bring pictures from home. Bring something that's really familiar so when they get to their bedside, it's like, this is your home. Oh yeah, that's right. Okay, this is my home. It's really difficult on family members when the person has at first been placed in long-term care and then they come to visit, that their family member just cries and begs and wants to go home with you. It was really heartbreaking. I could leave my mom behind. She said, please, please, please take me home with you. Oh, no, I can't take you home with me. This is your new home. Within a fairly short time, I would take her for a walk, come back to her room, and she'd say, oh, yeah, I'm home. So are you leaving now? Yeah, I'm leaving now. So this is your home. So it did get better over time. And then it got to where she didn't even know who she was. But initially in those stages. As far as preventing dementia, what do we do? Is it totally unpreventable? What do you think? Yeah? Lots of it. Yeah, there are things that will put you at greater risk, like the traumatic brain injuries, the concussions, the football players. But there's a study that was done, I think it's last year, at UCLA, and some researchers took all of the research that's been published, studies that have been done that point to positive things that you can do to prevent dementia. And they compile it all into the author. It's called 100 Simple Things You Can Do to Prevent Alzheimer's. And the author is Jean Harper. At any rate, the summary of that is that the thought is, after having reviewed all of the research that's been out here worldwide, that Alzheimer's is not entirely genetic disease process, and that it is somewhat, to a great degree perhaps, preventable. The most common things, they looked at all the research, as I mentioned, and they tracked down, it says, thousands of studies and interviewed dozens of experts in the field worldwide. The 10 strategies that this author came up with was, number 1, drink coffee. A large European study showed that drinking 3 to 5 cups of coffee a day in midlife cut Alzheimer's by 65%. Yeah. No, and that has to be caffeinated coffee because the research showed that the dementia-causing amyloid in their nerve cells, remember the amyloid, that protein that clogs everything up, that it doesn't cause that amyloid clogging in dementia.
Because you're going to die of a heart attack, not dementia.
So, drink up. The next one, interesting, floss regularly. Floss regularly. The health of your teeth and gums helps predict dementia. That is true, because a lot of research has now shown that. They found that having periodontal disease before the age of 35 quadrupled the odds of dementia in later years. Because if you have gum disease, if you have periodontal disease, what's that caused by? Bacteria, and you have inflammation continuously. That inflammation travels to your heart, chronic inflammatory process, even though you don't have immediate indicators that you have. It also causes your brain to have inflammatory processes going on. And again, dementia doesn't show up until this whole process, before you have signs and symptoms, will have gone on for years and years. Same with heart disease. So, older people with tooth and gum disease score lower on memory and cognitive tests, and so they speculate that an inflammatory process migrates to the brain, from the mouth to the brain. But studies have also shown it goes to the heart. Okay, number 3, Google. Google, do an online search. Stimulates your aging brain, even more than reading a book or doing crossword puzzles. So the biggest surprise, it says, novice internet surfers ages 55 to 78 activated key memory and learning centers in the brain after only a week of web surfing for an hour a day. So all of you probably have very little chance of getting dementia, but it's really much more. It says Google, but And then grow new brain cells. Impossible, scientists used to say. Now it's believed that thousands of brain cells are born daily. The trick is to keep the little newborns alive. So what works? What do you think? Aerobic exercise, a 30-minute walk every day, strenuous mental activity, eating salmon, and avoiding obesity, chronic stress, sleep deprivation, heavy drinking, and vitamin D deficiencies. So that'll help to grow new brain cells. Number 5, drink apple juice. Okay? Apple juice pushes production of the memory chemical acetylcholine. So, and that's the way the popular Alzheimer's drug Aricept works. Didn't know that. Okay? So mice given apple juice did better on learning and memory tests than mice who received water. So the dose for humans? How much? 16 ounces or 2 apples a day. So have a glass of apple juice in the morning and an apple for lunch, and there you go. Number 6, protect your head. Blows to the head, even mild ones, early in life, increase the odds of dementia years later. Football players have 19 times the typical rate of memory-related diseases. 19 times. Alzheimer's is 4 times more common in elderly who suffer a head injury. And that the Columbia University study found that accidental falls doubled an older person's odds of dementia 5 years later. That they would develop the dementia 5 years later. So wear seat belts and helmets when you're on your bicycle, or fall-proof the house for your older family members. 7 was meditate. Does anybody in here meditate? People who meditate regularly have less cognitive decline and brain shrinkage, a classic sign of Alzheimer's. A study at the Andrew Newberg University of Pennsylvania School of Medicine says yoga meditation of 12 minutes a day improved blood flow and cognitive function in seniors with memory problems. Okay. Take vitamin D. Vitamin D boosts older Americans' risks of cognitive deficiency of vitamin D boosts American risk of cognitive impairment 394%. That's huge. And that was a study that was done in England at the University of Exeter. Most Americans lack vitamin D, so they recommend 2,000 units of vitamin D3. The number 9 was fill your brain. A rich accumulation of life experiences, education, marriage, socializing, a stimulating job, language skills, having a purpose in life, physical activity, and mentally demanding leisure activities makes your brain better, able to tolerate plaque and tangles, those fibrillary tangles. Avoid infections. Astonishing new evidence ties Alzheimer's to cold sores, gastric ulcers, Lyme disease, pneumonia, and the flu. The cold sore herpes simplex virus is incriminated in 60% of Alzheimer's cases. So the theory is that infections trigger excessive beta amyloid dump that kills the brain cells. So you don't have to take notes on all this stuff, but those are the 10 things that they mention on how to stay safe. Did you know all of that? So hopefully your generation will see less and less dementia because you're eating your apples, you're Googling, or you're doing everything that's safe for yourself. Okay, the next couple of slides. I think the next 4 slides have nursing diagnoses. I'm not going to go over them. I think they're self-explanatory. Some of you have dementia as a primary nursing and medical diagnosis. You may want to look at what your concept map looks like. Okay? What to do if the person has urinary elimination altered, what interventions might be helpful. Okay. Altered thought processes related to neuron damage, Alzheimer's disease. And some of these things, even though the goal would be that the person will, get better orientation, it's not going to change if they're already at a certain level. Alzheimer's just continually takes ratchets down in terms of their ability to perform skills. So these are some of the nurse actions that will help. I've covered most of those. Altered nutrition. Okay. IBW is ideal body weight. Oh, it's on there. Okay. The meals, offer the liquids, help to feed them their meals. Altered nutrition is important for all patients in long-term care. I used to visit my mom very, very regularly, but I was sort of staggered when I would visit the times. Sometimes I was there for lunch, sometimes I'd feed her dinner. I can't tell you how many times I came, and I missed maybe the lunch by the actual distribution of the meal trays. Because I try to do between classes, run over there, go visit her, feed her, and come back. And multiple times, I came in and I said, "Where's my mom's meal tray?" "Oh, she's already done." Because I knew she needed to be fed. "Oh, is that right?" So I'd go to the cart that had the trays in it, and there would be, nothing had been opened, not a fluid container had the plastic off of the container, and not a bite had been taken. So whoever, they brought it to her, set it in front of her, she didn't know what to do with it, didn't know how to feed herself anymore, swung by, picked it up, she didn't want to eat. Like, and if I would feed her, she would eat everything. Everything. It seems like every month or 3 or so, 3 or 4, she would get dehydrated. And the first sign of dehydration was she wouldn't wake up. She got really, her brain wasn't getting good perfusion because her blood flow was diminished, because her volume was getting diminished. And I would say, she's getting dehydrated. Have you not been giving her the fluids? Because I can't be here for 3 meals a day. They would start an IV, give her a liter of fluid, and I was at the point where she was still recognizing me. She said, oh, hey. But before that, she was so sleepy she couldn't even eat. That was just dehydration. So if they're able to eat and they eat everything when you feed them, then somebody needs to feed them. But I can't tell how many times that happened. The whole tray would just be placed back on the meal cart without having given her anything.
Still see that.
Do you still see that?
Yeah.
Or they take the tray away really quick. Like my patient, I had to feed her, and I knew she was so warm. I'm like, oh, she had a nut. And they did it in the dining room too, like, oh, that's nuts. And then they would take the tray. And I'm like, she's still working on it.
And we wonder why they have such poor albumin levels and they're so malnourished, because they don't want to take the time. But I used to it used to irritate me knowing that she had a wonderful appetite and would eat everything if you just took the time to feed her. And that's, I think, if I ever left for a weekend away or whatever, most of those occurrences were when I hadn't come to see her for 2 or 3 days for whatever reason I couldn't make it. And she would be so sleepy she couldn't wake up. Her eyes were closed, no response. But nobody else recognized that. I had big notes on the chart saying when she gets sleepy and she doesn't wake up, she's dehydrated. Don't let her get to that. When you start seeing her just sort of sleep all day, she's dehydrated, but fell on deaf ears. I think you now understand if there isn't someone advocating for someone in a nursing home, they die within how much time? 3 months.
Oh my God.
Yeah. On average. Not everyone does, because obviously you have people who've been there for years. But on average, it's not a very long time. So altered sleep pattern, yeah, they do have altered sleep pattern. They have that sundowning in the evening. When the sun goes down, they get agitated. The CHO is carbohydrate snacks under nurse actions. Okay. The next problem of older adults is acute confusion. It's also called delirium. Very, very common in long-term care as well as acute care. Probably we see it more in acute care because that's where they're in an environment where it's strange to them, they've had surgery. So delirium is the medically correct term for acute confusion. So acute confusion, delirium is the same thing. The big indicator that it's reversible is that it's acute versus chronic confusion. People who have dementia have chronic confusion. Chronic means long-standing, long-term, you can't fix it. So acute confusion is something that is very, very common. And it usually sets in the second or third day. Oops. Let me see. Next. Okay. Usually acute confusion sets in the second or third day of hospitalization. It's a very global cognitive impairment that has a very abrupt onset, and there are many, many underlying causes that need to be investigated to reverse the problem. There are different kinds, the hypoactive or hypoactive delirium. The hypoactive delirium is characterized by very lethargic behavior. They're just not, they're sleeping all the time. It's also called quiet delirium. The hyperactive delirium is associated with tremendous agitation, pulling out all their tubes and lines, restlessness, fidgeting, trying to crawl over the side rails. That hyperactive confusion, if you've tried everything else, those are the patients who sometimes end up with restraints on because they're just everywhere. They won't stay in the bed. Those are those patients who can wrestle all of the covers off of the bed, so they're laying on a bare mattress while they have restraints on. Most of the delirium that you will see is mixed delirium. It's not hypo or hyperactive specifically, but it's kind of a mixture. It's the most common kind. So more than half of the types of delirium is mixed, hyper and hypo. Sometimes you come in and you get report from the previous shift, and they'll say, yesterday when I got report from the day shift, they said that the patient had 4-point restraints and that the patient was agitated, trying to crawl over the side rails. I took the restraints off during the night. They slept quietly. And then the next day, you have that same routine. Extremely agitated, pulling out lines, and a whole different type of behavior set. So sometimes they're okay at night, or just the reverse happens. They have all these hallucinations at night. They're seeing ghosts in the room. They're seeing spiders on the wall. There's animals that are scaring them. So there's no predicting of when that happens. Okay, so the acute, as the title indicates, has an abrupt onset and generally lasts less than a month. Sometimes family members will bring it to your attention. If you see a patient who's post-op, and maybe they're in their 80s, you can make really quick assumptions that this person has some sort of dementia, that they must have been confused before they came in, and the family members will say, until he was admitted here 2 days ago, he was driving a car. He had no mental problems at all. So family members, if they tell you this is not how we recognize this individual, this family member, pay attention and start looking at what could have caused this acute confusion. 50% of hospitalized older adults experience acute confusion. Now that's huge, that's high, but delirium is unrecognized in 66 to 84% of patients. And that's partly, I think, the staff not recognizing that behavior that you're seeing isn't their common type of behavior, that they're normally awake and alert. But if you don't know that from family members and you don't have a chance to see the family members on your shift, then how would you know? Right? It's really important to be aware because if you do have someone who has acute confusion, they will have vital sign changes. This is important for you to recognize when you're assessing your patient. They will have tachycardia, tachypnea, and hypertension. So if you're looking at the admitting heart rate, respiratory rate, and blood pressure, it usually happens how much time into the hospitalization? When does it usually start? Second or third day. So look at those vital signs on there. Look at the trending. Where would you see the trending of their vital signs? On the graphic sheet, on the flow sheet. Okay? So if you're noticing that now they're tachycardic, tachypnic, and they have hypertension, they didn't have it on admission, start thinking about acute confusion and let the physician know so that if it's validated by family members that they were awake and alert before they came in, something needs to be done to reverse that.
So is it day 2 or 3 that shows up?
Usually between day 2 and 3. Not the first day, but often associated with post-op patients. They've had anesthesia, they don't recognize where they are, real significant change in their behavior. Sometimes we'll ask a family member to sit at the bedside and they will continually reorient them. It can be very, very helpful. And it's usually the family members who let you know that this is certainly out of character, this behavior. But look at the last item there, untreated acute confusion or delirium may progress to chronic cerebral dysfunction resembling dementia. Okay? Persons who have acute delirium have a 3-fold increased risk of death within 6 months, especially if they don't return to their previous cognitive level. So, 3-fold increase of dying within 6 months. Each additional day of delirium is associated with 20% increased risk of remaining in the hospital and a 10% increased risk of death. So it is not without consequences. So in hospitalized patients, delirium is a predictor of death for the most part. Okay, so they have delirium, it's not reversed, they're sent to a nursing home, and you know how it goes in nursing homes. There's no active trying to get them back to their previous state, and they just never regain their cognitive function, when in fact it's readily reversible. They haven't found any drugs yet that help it, so you have to figure out what the underlying cause is. The underlying cause of acute confusion can be medications, especially anticholinergic drugs, sedatives and analgesics. So those anticholinergic drugs, give me an example of one that the patient may have had who had surgery. Atropine. Why do we give them atropine? Yes, to reduce the number of secretions, to kind of dry them up. So, but the atropine, the anticholinergic, also inhibits transmission of parasympathetic nerve impulses. So it it blocks their acetylcholine receptors. You need acetylcholine for those nerves to function. Medications, especially Demerol, we no longer give Demerol to older adults, hardly ever, because Demerol, when it is metabolized, what's Demerol called? Meperidine. When Demerol is metabolized, the byproduct is normeperidine, when it's broken down and metabolized by the liver. And normeperidine is neurotoxic, and especially very, very great degree of cognitive dysfunction in older adults. Analgesics as well can have tremendous side effects in terms of their cognitive ability to function. Metabolic disturbances such as electrolyte imbalance and hypothermia. So post-op, keep them warm. Look at their electrolytes. If any of their electrolytes are out of whack, IV therapy can often reverse that. Nutritional deficiencies, we already talked about nutritional deficiencies. If their protein levels are really low, address their diet. Infections and surgical operations, we see it very commonly in people who have sepsis as well. And then circulatory, renal, and pulmonary disorders often are associated in older adults with acute confusion. And the last one is major loss. Sometimes people attribute to family members as well. Maybe their spouse has died. You say, well, you know, and then he's hospitalized, and it's probably because he's depressed and he's not participating in his care, he's not aware, and so nothing is done to reverse that acute confusion. Signs and symptoms, lots of them are listed here. Insomnia, disruption of the sleep cycle, distractibility. Distractibility is loss of contact with reality. So they have very poor abstract thinking. They have hypersensitivity to light and sound, and that contributes to sensory overload, which makes them confused. So if you have lots of things whirling and hissing and beeping in a patient's room, then see if you can eliminate most of that, because sometimes that is the cause of their acute confusion. It just causes sensory overload. They can't manage all of those different sounds in their environment, and it makes them confused. Okay? They have very short attention span. They have diminished response to stimuli, usually. They have vivid dreams and nightmares. They complain of difficulty remembering, and these are the patients who know that they are confused. And it makes them very worried. Family members worry too. They will say, I don't even know where I am. You need to help me out. I don't know how I got here. Okay? And then you have to continually reorient them. That short attention span is kind of like reorienting them to who you are, where they are. That has a tendency to help. And getting them absolutely involved in their care. It's time to, for lunch, here's your tray, I'll help to feed you, but see if you can take a few bites first. Whatever you can do to get them involved. So some of the primary interventions for managing delirium: maintaining a homeostatic balance for the brain and limit stressors. So homeostatic balance for the brain means you're going to check electrolytes. Okay? Electrolytes are off, and if they're dehydrated, they will become confused. So adequate fluids. How are you going to check for adequate fluids? Interger. Check their eyes, see if they're sunken. What else? The what? Their mouth, if their tongue is really dry, the lips are dry. What else will tell you if they're dehydrated? Low urine output. Yes, absolutely. The daily weight's important for people who have fluid volume excess. So provide adequate fluids and nutrition. How much fluid should they have a day? At least 2 liters a day, right? To make sure that they're not dehydrated. If they are dehydrated, to correct that. Mental and physical activity, keep them oriented, involve them in their care. Okay, allow the patient to make decisions about their care. These folks do not have dementia. Avoid the use of drugs that could alter their behavior. Use non-pharmacologic approaches for sleep and pain if you can. If you do give them pain meds, remember we start low and go slow with adding another dose or another drug. And then maintaining their dignity and independence. Don't treat them like a child. Just because they're confused doesn't mean that you need to treat them as though they're a little child who needs to be directed. So try to get them reoriented. Get their eyeglasses on, their hearing aids in, and minimize transfers. Every time they get transferred to a different room, you're dealing with a new environment. They don't know where they are. So if they do have acute confusion, we try to keep them in the same hospital room and not transfer them from one place to the next. Nursing diagnoses listed here. Just in general, providing orienting cues where they are, have family members at their bedside. We try as much as we can not to put them in restraints. Those meaningless stimuli, those pulse ox monitoring devices that keep beeping. If it's absolutely needed because they have low O2 sats, never ever turn the alarms off. But if they're at a point in their post-op phase where that has been stable, they're not on O2, then that needs to be turned off. So you can just check it maybe every 4 hours or every 2 hours. The continuity of care, the same staff is helpful, the family members at the bedside. Encourage, like I had already said, participating in their own care, and respect their personal space and privacy. If they say, leave me alone, and they have a lucid phase, and don't hover over them and be in the room every minute of the day, and that goes for students as well. You have a tendency, because you have so few patients, just hang around. So if the patient seems to get agitated because you're continually doing something for them, give them some rest. Okay? Okay, here's a question. Oops. Remember the vital sign changes?
Increased heart rate, respiratory, and BP.
Yes, so tachycardia, tachypnea, and hypertension. If you look at the trending and they didn't have it before and they're confused, they have acute delirium. And family members get very, very upset when their own, whoever it is in the hospital can't even recognize them. They get really concerned, and the patients, like I said, will know that they're confused, and they get really they're just beside themselves that they can't remember, they don't know where they are, and then people remind them. It's like, well, I don't even know how I got here. Okay, the next slide talks about elder abuse. How many of you saw a video on elder abuse? Looks like 1 clinical group, 2 clinical groups. Not everyone, right? Those of you who went to Westminster saw elder abuse? No? Care house saw the video, okay. Elder abuse is a significant problem, afflicts up to 1 million or more older adults, so 32 out of 1,000. are suffering from elder abuse. Victims are most often women over the age of 75. Why is that? They live longer, yeah. The person who's abusing them is most often the spouse or an adult child. And neglect accounts for a large percent of elder abuse. So elders who know that they're being abused in terms of neglect, they're not getting the care that they need, they're often reluctant to report abuse because it's a family member. And what's going to happen if you are accused of elder abuse? You could go to jail, and then they don't have a caregiver, right? And these are their family members. I have an article from last year from statistics in Orange County, and it said in Orange County in 2010, there were 7,500 Orange County elders suffered financial or physical abuse. That was an increase of 7.5% over the previous year. If you suspect elder abuse, it is you are a mandated reporter. Those of you who saw the video, what does that mean? You must report it, even if you suspect it and you're not real sure. But if you suspect someone is being abused, you are a mandated reporter and you must report it. So you can't mention it to someone else or report it to someone else without following through, making sure the paperwork has been processed to report the elder abuse. The ones in Orange County last year, 29% were for financial abuse, the reports. So they take their Social Security check, they access their bank accounts, spend their money, but don't have money then to spend for their medications or care providers that they might need. 27% were neglect, usually by family members. And 24% psychological abuse, threatening them that if they don't do something or if they don't give them the money, for example, that they will not care for them. 16% was physical, 2% sexual abuse, and 2% isolation. Sometimes we see patients coming into acute care or long-term care and they have these horrendous, multiple stage 4 decubitus ulcers. Someone at home cared for them, didn't know the importance of turning every 2 hours. We've seen people come in with huge stage 4 decubitus ulcers. I mean huge. Big holes, gaping holes in their hips and in the lower back, at their shoulders, everywhere. And so those pressure ulcers develop quickly, but in some cases, family members who were supposed to care for them, the older adult was bedridden. They said goodbye in the morning, went to work, gone 8 to 10 hours, and then come home at night and the person hasn't been turned, can't care for themselves, they're laying in a soiled bed or whatever. And then I think many of the family members, I don't think they know that they need to be turned every 2 hours, and they don't know what to do when they develop all these big sores. So it's a real problem. We had a patient that came in some years ago, and she had at the lower part of her buttocks right here, stage 4, you can see her femur, the top of her femur, all the way across from one side to the other. The patient had MS, wasn't mobile anymore, and needed total care. The spouse fed her on the toilet in the morning because he didn't want to clean up after her. And so she would sit there as long as it took for him to get back. And then when she was brought in, we couldn't figure out that strange pattern of stage 4 decubitus ulcers at the bottom of her buttocks. And so it turned out he would put her on the toilet all day. No one was there to care for her. No one gave her food or fluids. And somehow he had something where she wouldn't fall off and came in with stage 4 decubitus ulcers. So that individual was charged with spousal abuse. Although that person was not an older adult, so it wasn't elder abuse, it was spousal abuse. There was also a patient at, what's the name of that facility in can't think of that, the facility where there are long-term developmentally disabled here in Orange County. What is it? Fairview. There was a person there, I think it was Fairview, a couple of years ago, who, when the nursing assistant started to provide care, had given birth to a stillborn.
Oh, yes, and then the trust in the diaper.
Yeah.
Yeah. What?
Yeah, had been sexually abused,
Yeah.
was not cognitively aware, and one of the caregivers had sexually abused her. She was pregnant. Nobody knew she was pregnant, and then delivered a stillborn.
She got transferred.
Oh, she
And
did?
then he had kept the baby in the diaper because he didn't want people to know that he had raped her. And then the police came to look at the baby, and then the baby is gone.
Oh, goodness, that was so sad. So, patients do get sexually abused. In this case, it was a fairly young woman. Older adults, female patients, are sexually abused as well, but they're not going to get pregnant. So, there are certainly indicators of the different types of abuse, but it happens more often than we would like to hear it happen. Okay, so there's physical abuse, and then it has some of the indicators of what you should look for if you suspect abuse. Okay. The next one, type of abuse, is neglect. That's 50% of elder abuse. They don't feed them, they don't supervise them for long periods of time while they go to work. The patient has consistent fatigue and listlessness. They have needs that are not being met, and they're being abandoned during the daytime, and those pressure ulcers again. Sexual abuse, I just mentioned an example of sexual abuse. And again, if it's a younger adult, the female patient, they may get pregnant, but these older adults are not going to get pregnant. So you have to look for signs and symptoms of sexual abuse. And then emotional and financial abuse. Intentional use of threats. Don't you report me. If you report me, I will never come and visit you again. Taking their resources, their financial resources, because they have no control of their bank account anymore. There was a patient we cared for, and we were talking to the social worker. It's been a couple of years. She was at the long-term care facility because her adult children or adult child who was the caregiver had sold her house, had power of attorney, sold the house, taken the money, and mom was left homeless. So that's an example of sort of a pretty significantly rare, hopefully, example of financial abuse. But then there's nothing they could do. The adult child had power of attorney, spent the money, or said they didn't have it anymore, and the person had nowhere to live. Okay. So what are some of those interventions? You have to be familiar with state and federal laws regarding reporting of elder abuse. You would report it if they are in long-term care. They have posters. Did anybody see the posters about who to report abuse to? Who do you report it to? The ombudsman. Yes. So and they have the phone number listed, fairly large print. If it occurs in a licensed care facility, family members or workers will see the posters, and it's the Orange County Council on Aging or the Orange County Ombudsman. If it occurs at a home and you're the home health nurse and you suspect abuse, you need to call the County Adult Protective Services. So if they're in a licensed facility or some sort of a care facility in a home, because there are assisted living type of facilities and they're in a home, you need to call the Orange County Council on Aging, the Orange County Ombudsman. If you were the home health nurse or you have a neighbor who you know who's being abused by family members, it's the Orange County Adult Protective Services. You are a mandated reporter, and you must call if you just suspect abuse. So if you're that home health nurse, you need to all call, but the most important thing you need to do is get that person out of that abusive environment. So you would call, maybe if they have large decubitus ulcers, call 911, have an ambulance take them to an acute care facility for evaluation. The problem often is that even though you know that they have all of the signs of being abused and the person is cognitively intact, If they say no, you have to respect their wishes that they don't want care. But you still need to report it, but you can't always remove them if they're cognitively intact. But ideally, they would allow you to call 911 and to get appropriate care for the different types of abuse that they may be suffering. Provide written information on emergency on emergency numbers and referrals for competent patients. Say, well, you don't want to go now. This is the number you need to call. Should you change your mind, we can make arrangements for you to be in a safe environment. Okay. The next common problem with older adults is depression and suicide. So depression is very, very common. How many of your patients received antidepressives? Lots. Okay. Back to the previous slide, the elder abuse. I have the numbers here too, but one of the things I forgot to tell you is that if you suspect elder abuse of any kind, you have to file the report within 48 hours. So even if you make a phone call, you have to write a written report, and it has to be turned in within 48 hours. Failure to report can result in loss of your RN license and or jail, because we are, as nurses, mandated reporters. Okay. So depression is a psychiatric syndrome often encountered in older adults, but younger adults as well, but since we're talking about older adults here, it's not uncommon in older adults. And of course, suicide is the most devastating consequence of depression. It's steadily increasing, and most older adults who attempt suicide want to kill themselves. Younger adults often have sort of like they have an attempt at suicide, but they don't really want to die as a call for help, as we often say. Older adults don't have this call for help. They have a plan, they do it, and they're successful most of the time, first time around. So how do you think they kill themselves? Gun. Yeah, they use firearms. Every now and then we will hear about older adult, the police are called to a home and both of the older adults are maybe a sick spouse in a bed and then the other one is found dead with them, right? Or a neighbor will say, oh yeah, you know, the spouse is bedridden and he was the caregiver, and then maybe he's diagnosed with some disease process where he knows he can't care for his spouse. And so he'll kill the sick spouse and himself as well. It's probably more common than you realize. A couple of times a year, we hear about it here in Orange County. So they use guns and they're successful. I never asked you questions about statistics as far as numbers are concerned. There you go. 10 to 15% of all non-institutionalized older adults are depressed. 50 to 75% of long-term care residents have mild to moderate depressive symptoms, so about half of you raised your hand. So that statistic is pretty close to being pretty accurate based on your own patients. And then 10 to 20% of non-cognitively impaired adults meet diagnostic criteria for clinical depression. A lot of it is not treated, okay? Although it is very treatable. But a lot of patients are not treated because often it is not recognized as something that is true depression. Maybe they just lost their spouse, the death of a family member, and they seem depressed and they think it's part of that grieving process. We need to let our patients know that if they are depressed, that 80% are successfully treated and return to good mental health. Sometimes the meds that are being prescribed may not work. They generally don't work right away anyway. They may take up to a couple weeks for those meds to start working. So if you're caring for a patient who has just been started on an antidepressive and they say, I'm not taking this, they don't like the side effects, they've only taken it for a couple of days, it's not long enough for the drug to have worked, then encourage them to continue to take it and see if after a couple of weeks things don't change. If the side effects are such they don't want to take it, then talk to their physician and find out what it is that they could take that may not have those negative effects on them. Okay, so clinical manifestation of depression is very, very often missed. It's a common misconception that depression is part of normal aging. It is not. It is not normal for you to get older and to be depressed. But the reason is often unrecognized is because people think, family members think, that they're making an adjustment because of a loss. They may have the early stages of dementia, and they may also have some sleep disorders that make it look like they have severe depression, but it's not recognized. Okay, it's often misdiagnosed, and part of that reason is because people think that depression is a normal part of aging in many cases. And severe depression, there's a very high rate of suicide in older adults, and the suicide rate of older adults is much higher than young adults, teenagers in particular. Okay, all these signs and symptoms of depression. Sometimes they actually get to where they're in a vegetative state. They pull the covers over their head. They don't want any participation in activities of daily living at all. For whatever reason, if the family members don't recognize this, these patients die fairly quickly if that depression is not treated. So what can we do in terms of interventions? Provide a safe and supportive environment. Let the person know that depression is reversible and that it can be readily treated. Let them know that you care. Be non-judgmental. Talk to your patients. Sometimes patients will tell you that they've thought about committing suicide. Don't brush that off and say, oh, you wouldn't want to do that. But therapeutically, what should you say?
Why do you feel that way?
What makes you feel that way?
Yeah, what makes you feel that way? What else would you want to know? I'm sorry? Do you have a plan? Yes, and sometimes they'll tell you, yeah, I do have a plan. I talked to a patient once who was depressed and made some comments about life is not worth living, and that, why would he want to continue to live? And when I asked if he had a plan, he had a definite plan. Step by step, had given it lots of thought, and made it real clear to me that if the time came when he recognized that he was getting dementia or whatever, that he would just kill himself. So he had everything in place to be able to do that so that he wouldn't be like a family member that he had known who had dementia and just, had that sad, long time of just dying twice, as a lot of people call it. First when they lose their ability to be cognitively aware, and then when they actually die. So if they tell you they have a plan, make sure you document that and get a referral. Who do you refer this patient to? To the social worker, or get a referral for psychiatric evaluation. So try to help them as much. Refer them to support groups. If you know that someone has just had a death in the family, perhaps a spouse, many hospitals have grief support groups. When patients die, we give that to family members. Maybe that's what they need to be able to share whatever it is that's making them so depressed. Many older adults, the adults that are now in that age group of the older adults, would not consider support groups. It's like, I am not sharing my personal problems with someone else. I think younger people are more apt to follow through on that. That generation was very private and didn't want to share any personal information and don't want to do it at that point in time in their life either. So use reminiscence and guided life review. What does that mean?
Just them to open up about their life and their experiences.
Yes, if they're so depressed, life isn't worth living, talk to them. What did you do during life? What did you do? Do you have children? What is it that was really a happy time for you? Have family members bring photo albums in, and then looking back on their life, they'll see a lot of positive things that in fact they did have a very good life. That's very helpful. So that guided life review, and sometimes you, the nurse, will have to sit down with them and actually do that for them, with them. Okay. This is, I think we've pretty much covered this already. Emphasize they need to take their medication, that it's very treatable, that those symptoms will go away when the medication takes effect. Get them to participate in their own care. Turn on the lights, because often they want the lights off. Make sure they have glasses and hearing aids in place. Provide structure, security, and consistency in their care. Just making them feel like they're special and that you do care about them and that they are an important part of other people's lives as well. So those medications, as I mentioned earlier, sometimes they want to take the meds, they don't do any good, and they don't like the side effects. But if you look at the side effects, blurred vision, constipation, dry mouth, urinary retention, orthostatic hypotension, fatigue, weakness, drowsiness, tremors, and hallucinations. Kind of like, why would I take this medication? I'd rather be depressed. If they have, the reason they won't take the meds is some of these side effects, tell the physician and ask to have those meds changed. But many times you have to just tell the patient to bear with it, and that in a couple of weeks they may in fact feel a whole lot better. Okay, so they won't take the meds as prescribed. If they have complications or side effects like dry mouth or urinary retention, especially fatigue or weakness or drowsiness, have them not take it in the morning. Take it at night when they go to bed so they can actually sleep better. Okay, it takes a couple weeks for meds to become effective and to take them in the evening so that those side effects are diminished. In terms of suicide statistics, white men over the age of 70 have a higher suicide rate than any other age, gender, or race category. 23% of all suicides are committed by the elderly. They don't talk about their plans, they don't tell family members, and they just select the sure methods so that there is no question that the individual will, in fact, be successful in their suicide attempt. So look at those statistics. Older adults 5 times more likely to kill themselves than adolescents. We hear a lot about adolescents killing themselves, not so much about the older adults. Risk signs, medication misuse, self-starvation. I've seen that a couple of times. The self-starvation, the person is entirely healthy, other than being mentally depressed. They intentionally stop eating to die. And if they're cognitively intact, there's nothing you can do to make them change their mind. Family members will sometimes bring them in, but these are the patients who are at home and independent, and the family members don't realize that they're not eating intentionally. If you have a patient and they're talking about, I don't want to live anymore, they're talking nothing but hopelessness, that there's no reason to live anymore. If the patient is then admitted for an acute psych observation and you're assigned to that patient, if it hasn't been long enough for those meds to take effect, and the patient says, when you ask them how they're doing, things are great, things are looking up, I am better. Be aware, put them on suicide watch. They have come up with a surefire way to commit suicide. So if they hint to you that things will change soon, things are suddenly all better, but the meds haven't taken effect, put them on suicide watch. Watch them much more carefully. Often these patients are admitted to what they call geropsych units. They're not strictly in a psychiatric mental facility type of thing, but hospitals will have units called geropsych. These are some more statistics. 78% use guns to commit suicide. And I think we pretty well covered the older adults, especially the white men, males. They lost a spouse. they are unemployed, they have financial problems, they live alone, they've been identified as with perhaps a medical diagnosis that is not real positive in terms of outcome. They may have been drinking, become an alcoholic in recent months. They do have access to lethal means. A lot of people have guns. So if family members identify that they're truly depressed, we usually, when we talk to them, say, well, before your dad goes home, if he has any firearms, make sure that you remove them from the home. That's their method of choice. Okay? So risk factors, some of the questions you should ask. Have you thought life is not worth living? Have you considered harming yourself? And if they say yes, give some details. What is it that they have planned? And then have you ever acted on this plan? Younger adults who have a history of having perhaps made an attempted suicide. Sometimes you see people coming in more than once for attempted suicide. But generally the answer to this question in older adults is no. They haven't acted on it, and they do have a plan. And then you should certainly ask, have you ever attempted suicide? But since they use firearms, generally they haven't, because they wouldn't be there. Okay? So some nursing interventions. If the family isn't involved, get them involved. Get them involved in going to maybe the senior center twice a week for lunch so they can meet others and have some sort of social interaction with people. Include the patient in all the planning, promote independence and self-care, adequate mental health follow-up, certainly. They often need family members to participate in making sure that that happens. And, of course, taking their medications. Okay, nursing diagnoses that would be relevant to people who have severe depression, who may be considering suicide. Lots of them. Okay. What do you think? Violence, what does that mean? If someone is depressed and thinking about suicide, that nursing diagnosis of violence, how does that apply to this patient?
Could act out towards others.
I'm sorry, they what?
They may act out towards others.
Yes, yes. They get very angry that their life isn't going well, and they may have had some violent behavior, so we usually tell family members to really keep an eye on that person who's older adult who's depressed because they're not coping well. And maybe they've lashed out at people who normally would be close to them. Okay, some collaborating with older adults. Make sure you teach them well to prevent further deterioration of their illness. Emphasize the value of health promotion. Assist with relocation, helping them to adjust and to get engaged in whatever new environment they may be in. Be available to discuss issues related to death and dying. So if they truly have issues with perhaps having a diagnosis that is not reflecting, in most cases, a positive outcome in general for older adults, talk to them about an advance directive. The social workers often do that, but you as a nurse sometimes will just give the family members a copy of the advance directive, saying, you really should consider this. Your family member doesn't have an advance directive, and it would be helpful for you to help them with that. Living wills, estate planning, all of those things, if the patient's asking you, you need to respond to them about those questions. Okay, just a slide on ageism. It's one of the chief obstacles to securing high quality and appropriate health care for older adults. So tell me what examples you may have come across of ageism. What is ageism? It's a negative attitude towards older adults. Have you ever heard somebody just have these sort of blanket statements that they talk about older adults? The neighbors? Okay, tell me about your neighbors.
Don't walk on their grass.
They're walking on the grass?
Don't walk on their grass.
Oh, don't walk on the grass. So they are sort of just annoying old people? Okay. Okay, so the discrimination is basically based on their age. If a 40-year-old person neighbor said that, you would adhere to their request not to walk on their grass, right? But now this 80-year-old gets agitated because, by golly, you're walking on their grass. So you attribute it to they're just old and agitated, right? What else?
Driving.
Yeah, oh my gosh, an old geezer in the car, right? Speed up. Why are you going 50 miles an hour on a 65-mile-an-hour freeway lane, right? So we have all of these generalizations based on age. You look to see who's driving. Oh yeah, I knew it had to be an old person, right? But not always. Frequently they're not. So we have this, or many people have in their minds some undesirable characteristics that they paint everyone with. That, you know, they're terrible drivers, you can't walk on the grass,
Crazy.
and what?
The crazy.
They're cranky old people, yeah? So there are lots of myths and realities of aging, and I think it's on page 414 in Kosher that you should take a look at. Age and medical care. Some assumptions are, and there are people who believe this, that when you get older, you become senile. You get dementia. You are becoming incontinent, a bowel and bladder incontinence. And that you have sexual dysfunction, and that all of those things are inevitable and they're not treatable, and everybody who gets old enough has an issue with these things. So those are some ageist assumptions. And subjective experiences are discounted. Medical practice focuses on body systems, so sometimes it's not recognized. I have one example of ageism that happened to my mom. My mom was in that nursing home that I've told you about. She had dementia. And she had one of those chairs, one of those recliners that's electric, allows you to stand up without lifting the person up. And then they sort of back up to the chair while it's up. And you make a seat go down again, and they just sit down. The caregiver doesn't have to do a lot of lifting. My mom would sit quietly in the chair. She didn't try to get out. But one day, the nursing assistant set her in the chair and had a cord with a switch to make the chair stand up and to have her sit down and recline again. Sat her on the switch. But, you know, the chair was already where she needed to be, but didn't realize that my mom was sitting on the switch. So as my mom shifted her weight, no one was in the room. The chair stood her up. And she didn't know what to do when she stood up at that point in her life. She was totally unaware. And she pitched forward onto a metal trash can. Gashed her head open from here to here. And those scalp wounds really bleed profusely. So I was teaching lecture here, and they called and they said, your mom's been taken to the trauma center, you need to go. So I ended my lecture, went to the trauma center. And by the time, it wasn't in Orange County, so by the time I got there, an ambulance had already been called to bring her back to the long-term care facility. The people in that trauma center didn't like old people. You could tell when I first got there. It's kind of like, oh my God, get that old woman who has dementia out of here. We want something more exciting than this old person who has a scalp laceration. They wanted something exciting, some major trauma thing. A lot of people in the ERs are young people who just want some excitement. True.
Yeah.
And so when I got there, she was almost ready to go back. And like I said, the ambulance had been called to take her back. And I just had a chance to talk to the nurse who had cared for her and to the physician. That you could see she had sutures from here to here up to the top of her forehead. And from here to here, she probably had 30 staples. That's how big the laceration was. They took her back to the long-term care facility, and I sat with her at the bedside, and she seemed terribly agitated. And I could sort of read her behaviors because I was there all the time watching her and taking care of her, and I could tell she was in pain. And so I said to the nurse, I said, do you have the paperwork from the trauma center? Can I find out what she was given? Because I think she needs something else for pain. But she had just come back, so I didn't know what she had. So what do you think she had for pain? Nothing. So nothing was on the ER form, so I called, asked to talk to that nurse. And the nurse recognized who I was because I had just talked to the individual. And I said, what was my mom given for pain before you sutured and then stapled her scalp? And the nurse looked at the chart and said, you know, I don't think we gave her anything because, you know, she has dementia. She's old. So, and then verified that nothing was given. And I said, so you just injected locally with lidocaine? And the nurse said, we didn't do anything. We just sutured and stapled. And I said, surely, I said, I can't believe that a trauma center would do that to an individual, to a human being. But I said, that was my mom. How would you like your mom to be treated like that? Well, if you have issues with the care here, you can talk to our supervisor. And that was still the end of that conversation.
Can you sue? I mean, if
You can, and I actually checked on that. And you know what the attorney said? Your mom's life has no value as far as the law is concerned. She doesn't have a job. She doesn't have loss of, loss of. So he says, I don't mean that your mom doesn't have, that you don't value her, but in the trying to get, to sue someone for that, she said, don't even try it, because people look at this 80-some-year-old woman who has end-stage dementia, and,
It's for the future, it's not for your mom.
No, but I did talk to...
Future patients that are going to go
Yes. Yes, the individual is no longer there. It wasn't there several months later. That person was fired. I did talk to the board of directors, to the administrative director of nursing at that facility, sent everyone letters, chief of staff and the director of the ER and all of that. So, because it's a trauma center, a lot of traumas are coming in
Who
there.
was fired, the nurse or the doctor?
The nurse.
The nurse. So the nurse should have said, hey, when we do this, we got to give her some payment.
I don't know about the doctor. I wasn't able to find that out. So I don't know if the physician's still there. But the physician's name was on the paper that was sent home with her. So I did send a letter to the medical staff office after they placed in that physician's record. The administrators profusely apologized because that certainly, they had their mission statement posted and dignity of care and all those wonderful things. But I think the underlying thing was, this is an old woman who has dementia, get her out of here, we want something exciting. She's so severely demented, she doesn't know who she is, where she is, or can't talk anymore. Let's just get it done and get her out of here. I truly sensed that she had no value to them, and that, oh my gosh, give us some major trauma of some sort. So I think that's an excellent example of ageism. So the bottom line was, she got some Tylenol, 2 Tylenols we gave her. She swallowed them, and I stayed at the bed. Her blood pressure was out of line. She never had hypertension. Her heart was racing. She was so much pain and couldn't tell anyone. After we had the Tylenol given to her every 4 hours for the first day or so, she was totally calm and back to being herself. So, anyways, look at that first item. Older female patients are doubly at risk for discriminatory treatment. Who would have thought, right? Okay. And scarce medical resources are less likely to be distributed to older female patients. You probably don't want to hear examples, but my aunt, who lives in the Netherlands, is 88 years old, broke her hip last year. It's socialized medicine. They didn't fix her hip because she's too old and it cost too much, and just put her in a wheelchair. Yeah. So they're not going to fix it? Nope. So, there you go. My grandmother needed a pacemaker when she was in her 70s. Didn't get it because it wasn't was too expensive. They didn't have resources for that. So, still going on as of this current year. It's very, very rationed. You're not eligible after a certain age for certain procedures. And then just a little about social value. The more educated you are, the more wealth you have, the more influence you have, the more likely it is that you will have people who will respond to your needs. If somebody advocates for you, if you advocate for yourself, yes.
Marty used to work with a patient that was 108 and she felt real perfect and they did surgery on her.
Uh-huh.
Replaced her hip. And that's not, you don't care about that. She's 108.
Uh-huh.
And they did rehab and she was able to walk and everything.
Wonderful. And, if the person was very active before this happened and they were independent, there's no reason why they shouldn't maintain their freedom of movement and their mobility. That's not the case often with when healthcare is being rationed. Literally, it just doesn't happen. But I was listening on the news this morning that the payroll tax deduction has been approved to the end of the year. They're going to pay for it by reducing Medicare, taking it from the Medicare funds. So if there's just X number of dollars in the Medicare pot, then they're going to give less money to physicians. There's less money available for those who need medical care, and that's a pretty typical picture of socialized medicine. You can tell I'm not an advocate. I think it just destroys health care. Anyways, that's my soapbox. And many of you may not agree with that. That's just how it is. Okay. So, Patient Self-Determination Act. What is another name for that? What's it called? Human rights? To do what?
To make decisions.
Make decisions, yes. Individuals who have a right to make decisions about their care. So it's already been 22 years since that was passed, and it was intended to assist with making healthcare decisions when the individual is unable to do so. We had a case maybe 5 or 6 years ago. It was called the Schravo case. But prior to that, in the late 1980s, and I can't think of the name of that person, similar case, was a young woman who had been, I think, had taken prescription meds and drank alcohol and ended up in a comatose state. She was in her early 20s. Does anybody remember that case? None of you would remember that. At any rate, similar to the Schravo case, she was in a total vegetative state, was not responsive, and so a couple of years after she was in that state, she was on a ventilator, had been trached early on when she was first found unresponsive, and the family member said, you know what, our daughter would not want to live like this, so we want this life support discontinued. In the late 80s, and to this day, if you're an adult, another adult person, spouse, parents, whatever, cannot make decisions for you for your life. So the state will take the high road and advocate for life. They said she wouldn't want to live like this. She's been living like this for 2 years. She's never going to recover. She had contractures and was not aware of her environment at all. So they took it to court, and the court said, okay, they looked at it and they said, we have no evidence that your daughter would not want to continue to live like this. And so people who knew her testified, and they finally said, fine. If everyone who has testified is in fact aware of what you would have wanted, then we'll let you go ahead and discontinue life support. They did discontinue life support, but she kept living. She was breathing on her own. She didn't die.
14 days or something like that, a couple days.
No, a couple of years, I think, after that. So then she was still getting 2 feedings. The family went back and said, she didn't die. she wouldn't want to live like this. So at that point, they were allowed to discontinue tube feedings, and then she did die. But it was several years after the initial trauma, or whatever happened. I can't really exactly remember if it was trauma or not. I think it was overdose and alcohol, prescription meds and alcohol. Then legislators looked at this and said, wow, we need to do something about this, because we need to have some mechanism where people can state their wishes so that when they become no longer able to make decisions for themselves, there will be something in writing that states what it is they would want done if they were in a particular situation. So that's the Patient Self-Determination Act, passed in 1990, and it was intended to help family members who are left, to help them to make decisions about what the individual actually wanted. So what this legislation did was it identified and recognized that a competent person has the right to refuse life-sustaining medical treatment if they put it in writing before it happens to them. That they have to provide this information on admission, so anyone who's admitted to the hospital is always asked now, since that legislation was passed, do you have an advance directive, also called durable power of attorney for health care? So it's not power of attorney for financial things, it's durable power of attorney for health care. And so if you don't have it, they'll say, if you want the information, we'll give you this information and you can fill it out and you will have it. If you do have one, they ask you to bring it with you to the hospital so it can be put on your medical record. So it's documentation of the wishes of what they would want. So if you were to say, well, if I was in a car accident and I was totally unresponsive and in a vegetative state, and I've been on life support for whatever you want to say. Some people might say for a month, or others might say for a year. Nothing has changed. Whatever you choose, then turn everything off. I wouldn't want to live in a vegetative state. It just amazed myself and the students at those facilities where we have been, because 99% of the patients were in vegetative state. They were all trach, they were on vents, totally unresponsive, and yet they were closed. The families had no idea what the person would want, and they advocate for life. They don't want to say, well, yeah, resuscitate them. We don't want to lose them. They're still alive. So some of them were in their 80s and 90s, full codes. Well, when you think about it, they already have a trach, they're already on a vent. What else can you do? If they have a cardiac arrest, it's kind of over anyways. But resuscitation measures for someone who has a code will still be performed. So this is sort of what would prevent that from happening. As we were saying, gosh, if the person could answer, they'd say, oh my goodness, 5 years in a vegetative state already? Let me go. But those people didn't have an advance directive. So back to the previous slide, if they have an advance directive, the individual can change it every day if they want to. It is changeable until they no longer can competently make their own health care decision. Then whatever's in writing is what will be followed. So, and it's important that everyone over the age of 18 have one, because legally, there's no other adult who can legally make decisions for another adult without an advance directive. However, most patients don't have one, and then when you're in a hospital, the healthcare providers and the physicians will truly kind of talk to the families and say, this is the status and what do you want us to do? So they do in fact help to make decisions, but legally they have no authority to make decisions for another adult. Not the spouse, not the adult children, no one does. So if they advocate for continued life while you're in a vegetative state, that's what will happen if you don't have an advance directive, and the family members are making decisions for you. Living will is similar to an advance directive, but not nearly as focused. Usually living wills, to be effective, require that you be terminally ill and that you have about 6 months to live, which is kind of what most states have for living will. Many states prohibit healthcare providers from witnessing a living will, and that also goes for advance directives. If the patient has been given that advanced directive packet when they came into the hospital and they filled it out, they decided what a great idea, you as a healthcare provider may never be a signer as a witness on any legal document, including a living will or an advanced directive for durable power of attorney for healthcare, also called an advanced directive. So that is true for all hospitals that I've ever been in here in California. And most states have the same thing. So keep in mind when that patient that you're assigned to asks you to sign, tell them you may not. And again, with the living will, if wish is not clear, treatment will be provided. It's the same with the advanced directive. For a living will to be valid, the patient has to have, I think I said 6 months, 3 months or less to live. Many hospitals don't recognize them and do whatever they think a family would want to do. So the advanced directive is what most hospitals would adhere to. The advanced directive does specify about heroic measures, the living will does not. Okay? So if you want to get an advanced directive, I got one off of it online. It's called the California Advanced Healthcare Directive. And it's really easy. It's got pictures and real simple language. You just then decide what it is you want. Who should you choose? Guidelines on how to make it work. Life support treatments, what is CPR, dialysis, a breathing machine, blood transfusions, it lists all of that. End of life care, what do you want to do about that? Who your individual is that you designate. The choices that you want to make on your advanced directive. So it has questions like, my life is only worth living if I can talk to family and friends, wake up from a coma, feed, bathe, and take care of myself, be free from pain. So you just check which ones are important to you. My life is always worth living no matter how sick I am. That's the kind of person who would be at code when they're in a vegetative state. So you have that choice if that's what you want. If I'm dying, it is important for me to be at home, in the hospital, I'm not sure. If I'm so sick that I may die soon, it has choices. Try all life support. If the treatments don't work and there's little hope of getting better, I want to stay on life support machines. The other choice is I do not want to stay on life support machines. So get yourself one. Long time ago, I copied these, and at Christmas time, the whole family was together, and I gave everyone one. I said, now we're all going to sit down and figure out what we want, have it signed, because it has a couple of signatures, does not have to be notarized, does not have to have any legal intervention as far as an attorney. You just do it, get the signatures, and it's legal. So they all had one. My mom had one, and my dad had one, and everybody who I know had one. You don't have to list the spouse as your decision maker. My mother-in-law said, oh my gosh, if I had him, her spouse, if I had him make the decisions, he would keep me alive until, I rotted in the bed. So she said, absolutely not. I want you to make the decisions, and this is what I want. So it doesn't have to be the spouse. So make a copy of one, give them to all your adult children, your parents, your aunts and uncles, your grandparents, whoever you have. So this is kind of a summary. It's an advanced directive for healthcare decisions. Okay, durable power of attorney for healthcare decisions. So if someone says, oh yeah, so-and-so has power of attorney for me. You have to say power of attorney for what? To make decisions about your finances, to pay your bills? If the answer is yes, this is just for health care. Those other type of power of attorney do not apply to illness. There's no waiting period. You don't even have to be sick to make one. No legal and notary services are required, ever. And it may be changed at any time as long as the person who owns it is competent. It's the minute they become incompetent that whoever they identified will make the decisions based on what they identified as their wishes. Okay? Okay, a little bit about the end of life. Some of you, who was it that, one of our students, their patient died the very first day? Who was that? Tell us what happened.
The nurse said, like, on the Friday, after our first day there, he said that he was running on a speak fever. He said that he didn't know why nurses were so, taking care of him and using him, and because on Monday he was going to have to put him in quarantine, so he wouldn't be alive anymore. And then when we got there on that Monday morning, the nurse said, well, at 10, the case manager's coming up here and they're going to talk about what they're going to do. You can see they're helping me get off the ventilator. So then his family came there, and then I think 2 minutes.
So he was still cognitively competent. Okay.
And they got there and they discussed it, and then they took him off the ventilator and gave him morphine for comfort care. And they gave him 2 doses. They gave him more than he needed, and then he passed a lot sooner than they thought that once he was off the ventilator, he was going to last 2 hours, but he wound up dying in like 10, 15 minutes.
In comfort.
Yes.
Okay.
But he had already decided that he wanted to do it, so his family was there, and he was kind of just waving by to them and telling them to go, you don't want anybody here. And his family was like, we can carry out of the room, and we had the curtain drawn around the patient next to him, and his daughter was saying, like, I don't care what you're saying, I'm staying here till the end.
Did she?
Yes.
Okay, so that's an example of a patient at the very end of life who's cognitively intact, making the final decisions. I don't want to be on this ventilator, turn it off. The patients that we need advanced directives for are those who are already cognitively impaired, or they're already in that comatose state and they can't make those decisions. But another student of mine last semester had a patient. As a matter of fact, I talked to the patient maybe 10 minutes before she died, totally cognitively intact, having a conversation. She was sitting at the bedside. And I think 10 minutes after I walked by again to see how she was doing, she had died. So some people are totally aware and familiar with their environment and making decisions up until the end. Others, which is the majority of the time, are not participating in decision-making 10 minutes before they die. So you'll see the whole range. As a nurse, you are very, very privileged to be with someone at the end of life. Your presence there is important to the dying patient and the family members. So just understand how important a role you play at the end of life. If you don't know what to say, don't say anything. Just your presence is enough for whoever, the patient and whoever else is at the bedside, to recognize that you are there for them, patient as well as family members. It's a real privilege to be with someone at the end of life, to help that transition from life to death. There are lots of hospitals that you will be going to where they have a policy that no one dies alone. So if you have an actively dying patient and there's no one at the bedside, there will be a staff person or a volunteer. They have volunteers at a lot of those facilities who will sit with the dying patient and comfort them. So if you have a patient who's dying and you have other patients that you need to care for in most cases as well, you, needless to say, can't sit there the whole time while they're actively dying. But you can certainly see if they have those resources in your facility so that no one dies alone. It's kind of sad that, someone dies totally alone. Sometimes family members are there day and night, and then you take a break and go to dinner. The individual who's dying then dies because they really don't want to die in front of their family members. Others, just sort of nobody ever leaves the bedside, but there are many, many patients who die alone. There's nobody who comes to see them. So be aware of the role you play and how privileged you are to be there at the end of life. You're privileged next semester to see the new life in OB, but it's equally important for you to be that presence for dying patients. Really very important. My first patient I ever cared for, my very first day in clinical, was dead and I didn't know it. I told, I think, some of the students that. I was told by my instructor, you have a patient who has terminal CA. Now remember, I was a new English speaker, hadn't been here all that long, and I was like, okay, terminal CA, and she's no code. Terminal, bus terminal, train terminal. Terminal didn't have any sense to me of what it meant. Terminal. I don't know. I didn't know that that meant end of life. And all I knew was, as my first day in clinical, all I had to do was make an occupied bed, give her a nice bed bath, give her bed bath and do the occupied bed and make her look absolutely perfect, right? Before I started, I was told I had to do vital signs and quickly check, do system assessment. I didn't know what the values meant, so I remember having some real strange blood pressure numbers, and I don't know what they were. It was probably 40 over nothing. But I dutifully wrote it down. All right. So I know she was alive when I got there. By the time I finished the bed bath and the linen change, she looked perfect. We didn't have fitted seats on the bottom, so we were told they better be, like a military type of bed, tight, and everything had to be perfect. My instructor came in and she said, so Alice, how's your patient? Good, good. Doesn't she look great? She looked like she'd been starched and ironed. Perfect. Her hair was combed, she was clean. She said, did you take her vital signs? I said, I did. She said, well, let's do it again. Let's check it. Okay. She had the same type of stethoscope, double stethoscope that I have now. And so she said, okay, well, let's take her blood pressure first. And I think she suspected that the patient was dead, and I had no clue. Took the blood pressure, and my heart was pounding in my ears. I was so nervous. I'm sure many of you can identify with how nervous you are when your instructor's at the bedside. And I said to her, you know what, I can't hear a thing. I didn't see the needle jumping. And I said, I am just a wreck because my heart is beating so loud in my ears, I can't hear anything. She said, okay, well then let's just take an apical pulse. Okay. And so the other left, I think I was on the right, the other left. Okay. So I listened, and again, I think I could just feel myself just turning beet red and a wreck. And she says, so, what did you get? I was really frustrated, I remember, and I said, I'm telling you, I am just so nervous. My heart's beating in my ears, and I can't hear a thing. And she said, well, all right, let's go see what her respiratory rate is. Okay, just put your hand on her chest and watch the chest move. Nothing. My instructor says, so Alice, how long has she been dead? You're kidding me. And she said, no. Of course, it took a long time to do that bed bath, occupied bed, the whole thing. So I was probably with her for at least 2 hours, because it took me a long time to get that done alone. I didn't have a team member to help me out. And I said, I don't know. She said, was she alive when you started? And I said, yeah, look. And like I said, I don't remember the numbers, but it had to be something like 40 over nothing. And I remember when I gave her a bath, I noticed how blue her legs and arms were. She was actively dying, but I didn't know that. I know that now, but not then. When I rolled her over to do the back here, I noticed how blue she was near her buttocks because the blood was settling in the tissue. But I didn't know. So and then she said, oh, what a wonderful opportunity for you to do post-mortem care. Excuse me? I said, no, I'm going home. This isn't for me. I am going home. No, you're not, Alice. Come on. I'll get you another student to help you, and you can do post-mortem care. And I said, what is that? Oh, you're just going to get the body all ready and put tags on and take it to the morgue. I said, no. I'm not going to the morgue. Absolutely not. But I managed to just get through it, and it was a very traumatic day. My mom said, so, how was the first day in nursing school? I said, oh my God, you won't believe this. Mom said, how could you not know your patient was dead, for goodness sakes? I was so busy doing my tasks,
So, my story, my first day in clinical, I can understand how anxious you all are. All these years later, I can still feel that anxiety of my first day, so it never left me. So sometimes the barriers of quality care at the end of life is that the family doesn't want to give up, the patient doesn't want to give up, and or the physician or the medical team doesn't want to give up. So sometimes you'll see that the realities of life, limiting diseases are such that maybe sometimes we need to just refer patients to hospice care, to palliative care, but there's a great reluctance to give up hope. There's lack of adequate training of professionals about end-of-life care because there's this perception that if you say that I'm going to refer you to hospice, that it's a death sentence. People graduate from hospice every now and then. They get better, they just don't die, but they associate it with the last couple of weeks or days of life. There's tremendous delayed access to hospice or palliative care, and there's a misunderstanding that the person has only 6 months to live or less to qualify for hospice. That is not true. The most common fear of people dying is that they will be in pain and that they will be a burden, a financial burden to their family members. So often people who would prefer to die home end up dying in hospitals because there's medical futility. There are things that continue to be done for some dying patients that has no chance of having a positive effect or outcome. But you will see it as well when you start taking care of patients, like some of the ones that I mentioned who are still COs and they've been in a vegetative state for years. And it's ethically accepted to withhold treatment. If the person is awake and alert and can make decisions, the patient can make decisions to say, I don't want to do this anymore. Like your patient who wanted to be taken off the vent knowing full well that that was the end of their life. That is ethically accepted. There's no moral or ethical rationale for continuing life support when there is no positive outcome to be achieved. And you'll see some of this, that treatment is considered medically futile when the treatment affords no benefit, weighing the intrusiveness, burdens, and risks against the ultimate outcome. Sometimes patients are almost actively dying, they're at end of life, and yet we're still giving them chemo. That sense of we don't want to give up on you. And yet they could have benefited from being perhaps in a program with hospice staff, and the end of life would have been much more positive. Okay. If the patient at the end of life, if they have a advance directive, or the family member has decided to make them a DNR, do not resuscitate, then they become what we call a no code, a DNR, and that means comfort measures only. The goal of treatment is a dignified death. Many patients want to go home, and you as a nurse have to ensure that the patient is treated with honor and respect, that we maintain every effort to keep them as pain-free as we possibly can, and allow the dying patient to make treatment choices. We're not going to ask the family members to make treatment choices. If the patient's awake and alert, we're going to ask the patient. And to maintain the patient's will and hope, the hope of having a peaceful death. You can't take all the hope away from them. So maybe the hope is not only to have a peaceful death, but a pain-free death. So they can hope for the best death possible when they can no longer hope for a cure for whatever it is that they've been diagnosed with. So if you have a patient with a DNR, that means we're not going to put them on a ventilator, we're not going to intubate them, we're not going to resuscitate them in any way. No cardiac monitoring, we're not going to treat blood pressure increases or decreases, usually it's a decrease. So you stop everything. In many hospitals, a DNR patient, they take all the monitoring devices off, and we don't treat the things that you would treat if there were a code. Does that make sense to all of you? But we maintain their dignity, and it doesn't mean no care. No code does not mean no care. So we give them comfort measures. In some hospitals, they don't call it DNR anymore. They say do not attempt resuscitation, thinking that that sounds better than do not resuscitate, do not attempt resuscitation. And that generally means comfort care. So what does comfort care mean to you? Keep control, pain-free as possible. What else?
Regular treatment.
I'm sorry?
Regular treatment.
Regular treatment? Like what?
Continue with your care plan, but you,
Yeah, we don't abandon them. We give them regular care, okay? So usually, if the DNR is written and they're still in the hospital, we discontinue all IVs in most cases. We discontinue taking vital signs. In some places, they continue to do all of that, but for the most part, you're not going to act on anything anyways if vital signs change. We stop feedings. We order no more lab tests, because if they're as poor as they could possibly be, or high or low, we're not going to do anything about that. We suction the patient as needed, so they don't have discomfort of not being able to manage their own secretions. We take out the Foleys, but if the patient says that they would rather not be wet all the time and they're incontinent, if it's a patient's request, you can keep the Foley in. But we take everything out. We continue to give pain meds throughout, okay? And if the patient's not awake and alert, if they have a reasonable heart rate and there's no grimacing and they don't look uncomfortable, you probably wouldn't give them pain med. But as soon as they start getting agitated or they look restless, we will give them pain meds.
Would you still give them, like, making sure that you have thyroid issue?
No, we stop all of that. So no meds, but we will treat side effects of things. If they're getting anything that causes discomfort, we will treat all those things that cause discomfort. And family members are usually at the bedside for DNR patients. They probably need more care sometimes than the patient needs, so care for the family as well. The hospice and the palliative care are important services. Has anyone ever had a family member who received hospice care? Was it a positive perspective from the family members?
yes, because he doesn't want to be in the hospital where they put out
Didn't want to be in the hospital and all those tubes and all those invasive procedures, wanted to die at home. And so the hospice nurses and the team will provide really terrific care to the patient and the family. The focus is always on having the patient make the decisions. At the point where they can't make decisions, we'll see if they have an advance directive, and they'll have specific things that they may have requested. If they receive hospice, sometimes they have palliative care as well, concurrently. And palliative care would be to address those symptoms that cause discomfort. So if the patient, for example, is dying of lung cancer, but they develop a UTI, which can be very uncomfortable and painful and cause a lot of discomfort, then you would treat that UTI with antibiotics, even though it is near the end of life. You wouldn't let them suffer. So that's sort of the focus of palliative care, to look at what kind of relief they need for signs and symptoms of things other than what they're actually dying of. Hospice care, wonderful philosophy of hospice care. The philosophy is that death is a natural conclusion to life. The patient makes all the decisions as to how they want to live and die. The terminally ill can remain at home. Most hospice care is provided at home. Some hospitals have hospice units where a patient can go for respite care so the family can have a rest as well. They provide all the physical, psychological, and spiritual needs for the patient. The hospice nurses will provide medications, make sure that the person is comfortable. They'll have a CNA coming in perhaps to do the bathing, the linen changes. They have the family members participate in the care. And it's totally focused on comfort to keep the person as pain-free as possible and active as possible, and that they can stay at home with their families. Part of this whole hospice care is that the person who's dying is grieving and the family members are grieving, anticipating the loss. So there are different kinds of grief. The first one that's listed here is anticipatory grief. As soon as you get that diagnosis that says you have not long to live, that's considered anticipatory grief, grieving before the loss actually occurs, the loss of your own life as you look forward in time. Okay? And it can be actual or fear of potential losses on the part of family members as well. Maybe the spouse has never had a job and they need to go to work. So anticipatory grief is experienced by everyone in the family, including the caregivers. Next one. Anticipatory grief, I think that's what I just mentioned. The interventions are listed here. They are recognizing that their life is very short, help the family members with that on the disease progression so they know what to anticipate, encourage them to complete unfinished business, have wills drawn up, have things that they want done at the end of life with their belongings. You as a nurse need to provide your presence. Active listening, touch, and reassurance is really important for these patients who are grieving, especially when you're the first one at the bedside after they've gotten moved, that their disease process is such that they don't have much longer to live. Normal grief, then there's complicated grief. I think the grieving slides are pretty much self-explanatory. I don't think I need to finish all these slides. Mass grief, disenfranchised grief, someone who's grieving but they can't grieve openly. Like an ex-spouse, an ex-partner, they can't share their grief with others. Some of the interventions, if you're the nurse and people are grieving, your presence again, that active listening. Sometimes people don't know what to say, it's better not to say anything. And it's totally inappropriate, for example, to say, oh, your loved one is going to be in a better place. That's totally inappropriate, don't say that. You don't know that they're going to be in a better place. What else do people say? I don't know. At the end of life, what are some of the things people would say?
It's not suffering anymore.
Oh, she's not suffering anymore.
It was for the better.
It was for the better. Look at how he was suffering. So those are considered inappropriate, unprofessional things to say. Well, what can you say to these patients?
Sorry for your loss.
Sorry for your loss. Yes, absolutely. And just be there. Put your arm around the family members. Hold the patient's hand. So dying patients need a lot of physiologic support. They have things that change at the end of life that require you to provide care to them. And so that physiologic support, meaning that you're going to give them personal hygiene support. Okay? They need personal hygiene measures. They become incontinent. They need to be kept clean. Is the time up?
Yeah.
I heard all these zipper bags. Go and enjoy the afternoon.